Good evening, everyone. Thank you so much for joining our webinar about the preoperative care, or excuse me, the perioperative care of lower extremity vascular surgery. This includes infrainguinal bypass surgery and major limb amputation. We'll review the SVS and ERAS endorsed recommendations for the perioperative care in these two operations. Implementing ERAS protocols has been shown to reduce recovery time, but more importantly, it also reduces complications and readmissions. It also improves patient and staff satisfaction. Through a series of pre-recorded talks, we will introduce the general ERAS concepts to you, also provide details of the published vascular ERAS guidelines, and share some real-life examples and experiences from those who have already built ERAS programs. I'm excited to be joined by several subject matter experts this evening. As you can see on the slide, we have anesthesiologists and surgeons from both the United States and Europe. They all contributed to the ERAS documents that we will be reviewing tonight, and I'm forever indebted to the work that they contributed. In order to keep us on time, we've asked our panelists to pre-record these talks, and we'll begin with mine, an overview of ERAS, and will help answer the question of why we need ERAS in vascular surgery. Thank you all.
Hi, I'm Kate McGinnigal, and I'm so happy to have the opportunity to share with you all a little bit of background about enhanced recovery after surgery, specifically why I think we need ERAS in vascular surgery. I don't have any relevant disclosures to the talk today, and I think it should be no surprise to any of you that our patients with vascular conditions are really complex. In fact, across all surgical specialties, vascular patients are among the most comorbid patients, with a mean Ehlers-Danlos comorbidity index of 3.5. This really only compares to cardiac surgery patients and is significantly more complex than the other surgical fields that are considered high risk. And overall, the comorbidity profile of all surgical patients has been increasing over time. This is for both elective and emergent cases. And as such, our complication rate is high. Here in the VQI, you can see that the major complications after infrainguinal bypass surgery for patients with CLTI is about 5%. And there's quite a bit of variability across the country. Now, here I am in the Carolinas, and you can see we enjoy only a 3.5% major complication rate after surgery, despite the fact that most of our patients are overweight and smokers, seeing as that most of the state is covered in tobacco fields. However, wouldn't it be wonderful if we could figure out what we were systematically doing to get these good outcomes and share that with the patients who have higher than expected outcomes, poor outcomes. And our admission rate is high too. This, of course, goes along with the high postoperative complication rate. And you can see here, this is from Medicare claims data from about 10 years ago, that 15% of patients who have undergone lower extremity bypass surgery will be readmitted for an unplanned readmission. This is more unplanned readmissions than all other types of surgery combined. And of course, surgical outcomes reflect more than just the intraoperative care. Although we are able to create beautiful technical bypass anastomoses, there's a lot that can go wrong between the completion of our operation and the patient's full recovery. Healthcare spans many, many, many different types of clinicians these days. And in fact, during a 4-day hospital stay, patients can interact with over 50 different employees of the hospital, including nurses and physicians, but also technicians and therapists and other aides. And this breadth of interactions and the multiple different communications and decision points can contribute to the variation in care and also the gaps in care. So this can be seen as mass chaos, of course, but it can also be seen as an opportunity to standardize care and improve the quality overall. And that's where ERAS comes in. ERAS is enhanced recovery after surgery. It's a comprehensive perioperative care pathway that pulls together your individual expertise as a surgeon with the best external evidence, not just from vascular surgery, but from other surgical guidelines and other non-surgical fields. And it marries those things with the patient's values and expectations, so you can choose the best operation and course of recovery for the patient that's sitting in front of you at that moment. And this synergy of evidence-based practices really meets in the middle and helps get our patients through surgery more safely. ERAS started a couple of decades ago, actually. The first formally published pathway was in rectal surgery in 2009. And soon thereafter, there was a nonprofit medical society called the ERAS Society, which is still thriving today. And through this society, multiple other specialties started to explore and develop ERAS pathways. You can see there's a long list of surgical specialties here on the right side of the screen. And Vascular Surgery has published its guidelines over the last 3 years. The first was the open aortic guidelines in 2022, followed by lower extremity bypass guidelines in 23, and then this year, guidelines for major limb amputation. Now, you may think that vascular is a little bit late to the game, but I'd say that during this same time, we also had an explosion of growth in endovascular techniques, which is its own way of reducing the stress of operations and getting the patients the high quality complex care that they need. However, for patients who are not candidates for endovascular therapy, it's really incumbent upon us to learn from these other surgical specialties how to best take care of our patients who are undergoing open surgery. Additionally, there's been a huge growth in ERAS principles and ERAS pathways throughout different anesthesia specialties, as well as nursing and allied healthcare providers. And regardless of specialty, the principles are really the same. It starts with better preoperative organization. We tend to do pre-admission risk stratification. Of course, this is extremely important, especially for cardiac risk in our patients. But it takes it a step further and really thinks about patient optimization. This includes smoking cessation, reducing alcohol intake, working on high protein diets and improved nutrition, frailty assessments, delirium assessments, as well as patient education and expectation setting about what they can do to get themselves ready, not just for surgery, but also what to expect after they return home. Intraoperatively, there's multiple different anesthetic techniques as well as surgical techniques that can attenuate surgical stress. And then postoperatively, the focus is really on maintaining homeostasis and returning patients as quickly as possible to their normal physiologic function. This is not fast track, though. I want to make a clear distinction here between ERAS and fast track. And in terms of the nomenclature, ERAS is really a specific trademark name for enhanced recovery after surgery, and it indicates that the ERAS Society has endorsed the statements or the protocols. In Europe, there's a very robust ERAS program with the different quality registries and auditing systems, but in the United States, where we have multiple other different quality programs and registries, the trademarked ERAS is not as common. Instead, you're more likely to see something called enhanced recovery programs or ERPs. These have the same principles, but are not necessarily ERAS Society endorsed. Either way, this is distinctly different from fast track. Fast track is what you can see used in the much earlier literature, but it has much more variability in meaning than ERAS or enhanced recovery pathways. Fast track programs don't always include multimodal, multidisciplinary approaches. They don't always include patient engagement in the perioperative care. And sometimes, even if they were unrealistic, they set defined discharge date goals. And the focus of enhanced recovery really shifts the emphasis from the speed of the recovery to the quality of the patient care, from the diagnosis through their surgical cure and to their surgical recovery. And in fact, some of the people who first published on fast track care have now come out to say enhanced early and long-term recovery after surgery should be the primary goal of clinical pathways and not decreased hospital stay. And now the way I think of this pictorially is that going through a really curvy path like this one here on the top is hard to do at a high rate of speed. And instead of just going faster and faster and faster, even though that may become reckless, ERAS is really about straightening out the road and reducing the barriers. When everybody is chugging along in the same direction, the quality of the care is easier to deliver, and speed becomes a byproduct. a safe byproduct, I might add. And so multidisciplinary care and buy-in from all the different disciplines is really critical. To form an ERAS program at your hospital, we really recommend having a surgical, anesthetic, nursing, and a therapy champion who work together as kind of a core directing team. Having nursing care from the pre-op, post-op, and the nursing floor, in addition to the clinic, is really important since they are often the ones who can do a lot of the different coaching and patient expectation setting within the guidelines of an ERAS program. And audit of outcomes is extremely important. Having an ERAS protocol alone is not enough. We have shown and published that just adding a protocol is not sufficient to change practice, but consistently looking at what parts of the protocol are being adhered to and where there are struggles, connecting ERAS protocol adherence to surgical outcomes, and having possible feedback loops for quality improvement is really an important part of the process. And you don't have to adhere to all of the different ERAS recommendations to make an impact in patient care. And in fact, since every single patient is different, some patients may not be able to do all of the different recommended things, and that's okay. But in general, having everybody working together along the same lines to reduce the stress of an operation and to get patients back to a functional baseline status is the goal. And so in conclusion, ERAS pathways can enforce best practices, and that in turn reduces unwarranted care variation. With that, we reduce surgical complications and readmissions, and that creates backfill opportunity and improves the access to high-value surgical care. Additionally, when you have an ERAS program in place, there's a strong multidisciplinary framework for which to implement new practices. And so this is a great way to translate new findings from clinical research into practice. And I'd also posit that the ERAS can be a method for addressing healthcare equity and burnout and make your workplace better. When everybody comes to work knowing what they're supposed to be doing and how they should be working in unison with one another, a lot of the unnecessary barriers that we face on a daily basis evaporate. And so with that, I hope that you enjoy learning more about the details of the ERAS for lower extremity bypass and ERAS for major limb amputation pathways and the rest of this webinar. It's an honor to be here. Thank you.
Okay, our next presenter is Dr. Hans de Boer. Dr. de Boer serves as the ERAS Society Executive Committee Chairman, and he is a staff anesthesiologist and pain specialist in the Department of Anesthesiology at Martini Hospital in the Netherlands. His interests include neuromuscular management, perioperative management of pain and patient safety, and also innovations in anesthesiology. He has implemented opioid-free and opioid-sparing anesthesia techniques. Dr. de Boer, thank you very much for joining us this evening with a presentation entitled Using Regional Anesthesia Techniques in Lower Extremity Surgery.
Well, good day to you all. It's a great honor to participate in this webinar on using regional anesthesia techniques in lower extremity surgery. These are my conflicts of interest, and this will be the agenda for today. I will discuss some healthcare challenges. I will touch surgical stress response modulation and answer the question, is there a relation between pain and complications? I will also discuss the role of regional versus general anesthesia techniques and draw some conclusions. This landmark paper from The Lancet about a global surgery in 2030 reports on the healthcare challenges we have. About 5% of the population operated in the Western world, which means almost 320 million operations annually, of which 25% will have complications after surgery. And we have to realize there is a huge variation in care, and it takes more than 15 years to change practice globally. We also have an aging population, demand for better care, and diminishing funding. So we will concentrate on complications. Complications due to surgery consist all of this Anatomy of the surgical stress response. It starts all the surgery with a first incision stressor. Local tissue injury will occur, and it goes up to the peripheral afferent pain and nerve injuries, but also goes higher up to the spinothalamic tract. Neurotransmitters are involved, and anesthesia stressors are also added, which leads higher up to a central nervous system neuroinflammation. There is also a disbalance between the parasympathetic and the sympathetic outflow. There's also systemic inflammation and coagulation involved. And due to the surgery, the surgical stress, there will be a whole body and organ dysfunction. And this is more or less a compendium of the previous slide. You can see that the systemic response leads to an increased oxygen consumption, increased metabolic rate, increased temperature, and a protein catabolism loss of lean mass. And it results in a blood flow maldistribution leading to ischemia. And this leads all to complications, and we have to prevent it. But how to reduce complications? The modulation of surgical stress perioperatively is key in ERAS. It gives a reduction of complications, lower pain scores and discomfort, and it leads to an early mobilization and early recovery. So the interesting question now is there an association between complications and post-surgical pain? This research group published in the British Journal of Anesthesia in 2020 about the association between postoperative complication and lingering post-surgical pain. It was an observational cohort study. And their hypothesis was that major medical complications after surgery are associated with an increase in pain that lingers beyond the acute post-surgical period. And they found that major medical complications after elective surgery are associated with about a twofold higher risk of developing such pain. Apart from severe pre-existing pain, postoperative medical complications were the strongest independent predictors of lingering pain 1 to 3 months after surgery. So it's more important to realize that we have to prevent complications. And the strong association between complications and lingering post-operative pain is consistent with emerging research, like with immune dysregulation or uncontrolled cytokine release sustained inflammatory state. And it will all have the development to alter nociception and hyperalgesia. However, no single complication was responsible for these findings. Let's take a closer look now to the role of regional anesthesia techniques compared to general anesthesia. These are the elements in the protocol which we published on the intraoperative, the anesthetic protocol, and the postoperative, the multimodal analgesia and opiate reduction strategies. But we have to realize that although the role of regional anesthesia in ERAS has gained interest in recent years, there remains no clear evidence favoring regional, spinal epidural or peripheral nerve blockade, or general anesthesia over the other. Let's take a closer look to the literature. This group reported about the utilization of regional versus general anesthesia and its impact on lower extremity bypass outcomes. It was a retrospective analysis of prospectively collected vascular quality initiative data. And their findings were that regional anesthesia was used in 3.5% of more than 16,000 patients undergoing lower extremity bypass and was associated with lower rates of congestive heart failure and postoperative renal dysfunction and shorter hospitalizations. There was no survival advantage. And their take-home message was that this study suggests that regional anesthesia may have some benefits in patients undergoing lower extremity bypass surgery. In another study, published in 2022, on modern lower extremity bypass outcome by anesthesia type in the veteran population, They investigated 23,000 patients in the Veterans Administration Quality Improvement Program database. And they showed that the incidence of prolonged ileus, pneumonia, reintubation, deep wound infection, sepsis, and the number of the RBCs transfusion are higher in the general anesthesia group compared to the neuraxial anesthesia group. There were no significant differences between the incidence of graft failure, return to OR, myocardial infarction, death, or the average length of stay. The take-home message of these authors was that anesthetic choice for lower extremity bypass may play a role in post-surgical outcomes following lower extremity bypass. However, graft complications and 30-day mortality were not significantly different between general anesthesia and neuraxial anesthesia groups. And this may represent a more surgically complex cohort in those that undergo general anesthesia, as opposed to neuraxial anesthesia, rather than the effect of anesthesia type, and should be further investigated. Another important study was the Cochrane review on the neuraxial anesthesia for lower limb revascularization. And these authors' conclusion included available evidence from included trials that compared neuraxial anesthesia with general anesthesia was insufficient to rule out clinically important differences for most clinical outcomes. Neuraxial anesthesia may reduce pneumonia. No conclusions can be drawn with regard to mortality, myocardial infarction, and the rate of lower limb amputation, or less common outcomes. This is also an interesting study by the study group who reported on the neuraxial and combined neuraxial general anesthesia compared to general anesthesia alone for major truncal and lower limb surgery. This was a systematic review and a meta-analysis. And they found that perioperative outcomes were compared with general anesthesia for the following subgroups: combined neuraxial general anesthesia and neuraxial anesthesia alone. 27 observational studies and 11 randomized controlled trials were identified. This analysis comprises more than 1 million records from observational studies or databases and more than 1,100 patients from randomized controlled trials. And what they found is they compared general anesthesia, neuraxial anesthesia when used alone or when combined with general anesthesia was not associated with a decreased 30-day mortality. General anesthesia, however, may protect against myocardial infarction compared to neuraxial anesthesia. And neuraxial anesthesia, when used alone or when combined with general anesthesia, may improve important perioperative outcomes when compared with general anesthesia. Neuraxial anesthesia alone was associated with a significantly reduced incidence of pulmonary complication. However, due to the inclusion of observational studies and database records within this analysis, results should be interpreted with caution. So, in conclusion, we have major healthcare challenges. More than 25% of our patients will face complications after surgery, and we have to prevent this by modulation and reduction of surgical stress response, which is key in ERAS. Major complications after surgery are associated with an increase in pain that lingers beyond the acute post-surgical period. So it's important to prevent complications after surgery. Although the role of general anesthesia or regional anesthesia in lower extremity surgery has gained interest in the recent years, there remains no clear evidence favoring regional, spinal epidural, or peripheral nerve blockade, or general anesthesia over the other. Thank you for your attention, and I hope you enjoy this lecture.
Thank you so much, Dr. De Boer. Next this evening, we welcome Dr. Roberto Settembrini. He is a vascular surgeon at the Fondazione Policlinico in Milan, Italy. He's also the adjunct professor of vascular surgery at the University of Milan. And notably, he had formative experience at the Novara Hospital with Dr. Piero Brustio, who is a pioneer in ERAS for open aortic surgery. This experience really allowed him to know and understand and deepen the ERAS approach that they take to aortic surgery in Milan, and he has successfully expanded his program to lower extremity surgery as well. Dr. Settembrini's presentation is titled ERAS for Lower Extremity Surgery, Current Guidelines and Review of the Literature. Thank you.
Hi to everyone. First of all, I would like to thank once again Society for Vascular Surgery for this opportunity, and Dr. McGinnigal and Dr. De Boer to have led our fantastic group about ERAS guidelines. Today, I will present you the guidelines for the lower extremity surgery. And as everybody knows, PAD is increasing in the epidemiology of the different countries, and in 2010, estimated 200 million people were afflicted with PAD, and in the US, the prevalence is almost 6% in patients older than 40 years. And PAD usually evolves to CLTI with a higher number of with a high risk of amputations and death in 1 year. It's important to underline also the high level of cost impact of the patients affected by PAD. So why we decided to evaluate the ERAS for PAD? Because the prevalence in the high-income countries on the left side of this picture, the prevalence has an exponential trend according to age increasing, rather than the lower income countries. So, looking to our framework published in 2023, led by Dr. McGinnigal, we can say that we evaluate the literature about 3,460 citations, almost 100 studies addressing ERAS, and 45 of them involved patients treated for the PAD. And looking to the recommendation, in the pre-admission, we suggest with a high grade the screening of the smoking cessation, also the medical and cardiological risk, and also the glycemic control before the intervention, and the treatment, medical treatment with antiplatelet or anticoagulation. Similar to the ARTA, also the fasting before the surgery is allowed till 2 hours, and also the carbohydrate loading and the treatment for the venous thromboembolisms, and also the antimicrobials treatment. Looking also to European Society Vascular Surgery guidelines, you can see how is important the clinical evaluation for the patient affected by PAD, because you can see the green suggestions that shows the high level of evidence for the suggestion of the guidelines. Also about the treatment, you can see here the different medical therapies, anti-diabetic drugs, antihypertensive, lipid-lowering drugs, and everything with a very high level of evidence, or a lower but still important level of evidence with the yellow box. So, dipping into our guidelines about the pre-admission, it's important the preoperative education and counseling, especially about the early mobility, the postoperative pain control, and the length of stay of the patients. The information about surgical procedure to reduce the anxiety and to improve the patient engagement. It's mandatory the nutritional optimization and the smoking cessation. Poor nutrition in patients with PAD is very important because can increase the mortality and the risk of major amputation. Also, the wound healing is reduced, and the mobility, the limited mobility due to the rest pain can induce a decline in the basal energy expenditure. So they can reduce the insulin sensitivity, the muscle strength. Nutritional management is mandatory in all the patients affected by PAD. The treatment of the preoperative anemia has a quality of evidence low, but it could be important in ERAS patients because the correction of the anemia may reduce the need for transfusions, and also in the intraoperative intervention management. The screen for frailty has a quality of evidence moderate, but frailty is important in vascular patients, especially in the patients affected by PAD, because frailty is associated with major complications, and the frailty screening can be utilized to evaluate alternate treatments for these patients. The smoke cessation has a quality of evidence very high. We know that current smoking is associated with almost 30% increase of major adverse limb events. And also we know that stop smoke between 4 and 8 weeks prior surgery can reduce from 23 to 47% of respiratory complications, and also can reduce the surgical site infections. About the medical therapy, looking to the SVS 2024 guidelines, we can see that endovascular interventions provide antiplatelet or dual antiplatelet medical therapy, and the open surgical revascularization provide also not only dual antiplatelet therapy, but also the anticoagulation management. So we suggest that continue aspirin throughout the perioperative period as a level of evidence high, and also the adjunctive anticoagulation therapy in prosthetic or high-risk bypasses as a level of evidence moderate. As I said before, fasting is important in these guidelines, but also in the aortic guidelines, and the level of evidence to encourage the clear fluids up to 2 hours and light foods up to 6 hours is important, with a level of evidence high. About the venous thromboembolisms, we suggest with a high level of evidence the treatment with low dose unfractionated heparin or low molecular weight heparin, because the reduced motility of these patients can induce the presence of venous thrombosis. Bundles programs to reduce the skin infections as a quality of evidence low, but we suggest to standardize the skin preparation. We suggest to do a prophylactic intravenous antibiotic treatment immediately prior to lower extremity bypasses, and the antibiotic duration is based on the presence of pre-existing infectious sources, the ulcers, rather than the non-infected tissue. In fact, in these cases, we suggest no more than 24 hours antibiotic therapy in the postoperative time. The prophylactic antibiotic before the surgery, between 30 and 60 minutes before the surgery, is has a high level of evidence with a high grade. Intraoperative, we can see that the key points are the anesthetic approach and the surgical technique. The key points for the surgery is the minimally invasive techniques, multimodal anesthesia, as we said, and normothermia. which groin incision, because the most important peripheral treatment approach is based on the groin incision for the distal bypasses, but also for the hybrid treatments. We suggest hybrid surgery with the treatment of the common femoral artery and retrograde or anterograde endovascular revascularization, or peripheral bypasses in case of not endovascular approach allowed in such patients. So, as a level of evidence low, the hybrid surgery and distal endovascular revascularization, but we can consider it in older patients to reduce the risk of skin infection site. About the groin closure, as a level of evidence low, the closure with subcuticular sutures or negative pressure, but there are some interesting results in literature about meta-analysis that suggest that this treatment could be helpful for a quicker recovery. About the drains, the avoiding of drains as a level of evidence moderate, the fluid management as the routinely used cardiac monitoring in these patients, not in aortic patients, but in these patients, as a quality of evidence low. So looking to the postoperative recommendations, we can see that the routinely use of multimodal analgesia is important in the postoperative of such patients, and also the glycemic control. The points are the early mobilization and the optimal pain management. And about early mobilization, the use of formal plan for early mobilization as a level of evidence low, but we know that it's very important in early mobilization in such patients for different reasons, not only the movement, but also to reduce the risk of venous thrombosis. As I said before, the oral feeding is very important, and the level of evidence is moderate, but we know that good nutritional state is important for the healing of these patients. And the level of evidence for written and verbal discharge education is low, but it's very important to increase the patient knowledge and satisfaction after such interventions. So in conclusion, we can say that ERAS pathways have the potential to greatly improve perioperative care for all clinical populations. The ERAS protocol should begin in outpatient clinic. It's a multidisciplinary approach, so in peripheral arterial disease, more than 70 people are involved per program, and the guidelines emphasize the importance of the multidisciplinary team in terms of the different important approaches. Thank you for your attention.
Thank you, Dr. Settembrini. I'd like to quickly remind everyone to feel free to add your questions through the Q&A box at the bottom of your Zoom screen. We will work to answer your questions at the end of this webinar and the panel discussion, and may even answer some of them through text as we're going through the webinar. Our next speaker is Dr. Ashley Vavra. She's going to join us with a recorded presentation titled How I Do It, Successful Implementation of Vascular ERAS Protocols for the Lower Extremity. An associate professor at Northwestern University Feinberg School of Medicine, Dr. Vavra also serves as the chief of vascular surgery at the Jesse Brown VA Hospital in Chicago, Illinois, and she leads the Enhanced Recovery After Surgery program as well. Performing both open and endovascular surgery for a wide range of disorders, she has particular interest in PAD and also thoracic outlet syndrome, another patient population that benefits greatly from protocolized multidisciplinary care. She's had great success in Chicago, and I'm looking forward to hearing how she's done it. Thank you, Dr. Vavra. The screen is yours.
Now that you've heard about the benefits of enhanced recovery for patients undergoing lower extremity arterial procedures, I'm going to shift a little bit and focus on the implementation of ERAS at your institution. I have no disclosures. And I hope many of you are excited or at least a little curious about implementing ERAS at your institution. But I do understand that that can be a bit daunting. So I'm going to talk about a framework that helped us both organize and motivate our team during the implementation, and some of the outcomes and lessons learned after we implemented enhanced recovery for lower extremity bypass patients at our institution. Before you get started, I think before you use any framework or methodology, I think it's worthwhile asking yourself 3 questions to assess whether your team is ready for ERAS. The first is, do you have a procedure that's appropriate for ERAS? In our particular case, patients undergoing lower extremity arterial bypass were outliers for both length of stay and complications in the VQI module we participate in. And therefore, we felt there was lots of opportunities for improvement. It's also important that you do the procedure regularly enough that it's not a big heavy lift for change. So our volume was significant enough that we weren't trying to reinvent the wheel every time a patient had the surgery and we needed to implement the changes proposed for ERAS. And then patients undergoing bypass at our institution are frequently admitted to our service. They are always admitted to our service postoperatively, and therefore they're on the same unit with the same team, as opposed to our amputees, which are frequently admitted to the hospitalist service, which could be on a variety of different floors with a rotating service of medicine physicians. So the complexity of intervention and the communication and the changes needed would be more challenging with those folks. So we stuck with the bypass patients. I can't say enough about identifying a champion to help get this through the finish line. You really need to have someone on your care team who cares about implementing ERAS and is up for the challenges associated. And I think it's important to consider partnering with other folks who have complementary expertise. Maybe someone who has experience with enhanced recovery, maybe someone who has expertise in quality or process improvement, and having a project manager can also help significantly in making this a success. And then I think it's important to decide or determine whether or not anyone else has successfully implemented ERAS at your institution, and then talk to them. They will help you identify what barriers you might experience, and also any resources you can use, like order sets or dashboards that you can help leverage for your own implementation. There are a variety of different frameworks for change that I think a lot of folks like. I personally like Cotter's 8-step model, change model. As is suggested in the title, there are 8 steps, but I do think it can be separated into 3 different phases. In the first 3 steps, you're really getting your team ready for change. You get a core group of stakeholders together. You identify what change looks like and also figure out how you're going to convince people to change. Then you disseminate that vision to all the people who are going to be impacted, solicit feedback so you can identify any potential barriers or problems that may limit your ability to implement successfully. And then it's important to keep people motivated. So can you establish small, quick wins throughout the process that you can provide motivation and opportunities to celebrate your early success? And then to make change stick, it's important that you identify how you're going to identify success, how you're going to measure it, how you're going to then communicate those successes or challenges back to your team and help make change a part of the culture. So I'm going to go through each of these different phases and talk about what this looked like at our institution. So instead of one team, we developed multiple different teams. We first started with a core group of vascular surgeon representatives from 3 different hospitals that included physicians, nurses, APPs, quality representatives, and trainees. And then we used that team to develop the initial care pathway and then ran that by different work groups that we created based on the phases of care. So we started with our core group, as I mentioned. We mapped out the current state and then reviewed that for opportunities for standardization and also which ERAS elements were relevant to our patient population by looking at the literature, expert consensus, and other enhanced recovery pathways. Then we took that care pathway and ran it by all of our work groups and finalized the pathway for dissemination. And looking at that pathway, we figured out which process measures we would be able to easily collect that would help support the success of our outcome measures. So if we had an improvement in length of stay, do we know for sure that that's based on the fact that we're doing the changes we think we're doing? And it's important to have process measures to evaluate that. And then finally, when you're thinking about how to disseminate your vision for change, you should also consider how you're going to convince people that change is necessary. I do think that having data to support that there's a decrease in the quality of care appeals to the values of most people in our line of work. So that went a long way for a lot of folks, including our care team and other multidisciplinary groups, for convincing them that change needed to happen. But I do think it's worthwhile considering what other return on investment people may obtain from helping to support this implementation. So administration is always focused on length of stay, convincing them that ERAS is a big benefit of reducing length of stay and what that impact they may have in a hospital throughput could be beneficial. It was for us. It also helps to explain how standardization of care can reduce the burden of communication and variation, so people are less likely to miss things, improves the experience of both the care team and the patients. And ERAS is big on setting patient expectations and education, so improved patient experience and outcomes are also benefits to the care team or those providing the care for them. You then take that vision for change and then disseminate it to everybody who's impacted. And because that's a very large, wide range of folks, I felt it was helpful to map them out on this influence relevance matrix to help identify how to communicate and how frequently. So for example, our surgical team needed a lot of detail. So we had a lot of frequent in-person meetings to review both the care pathway and to solicit feedback about how things were going once implementation was underway, versus our surgery scheduler, who was impacted by a very small portion of the changes that we proposed and really didn't need to be included on lots of very detailed communication. So electronic communication and then just a few check-ins to make sure things were going smoothly were sufficient for that individual. And then you want to identify as many obstacles up front as possible, but you've got to anticipate there will be challenges. So providing people with a mechanism for getting back to you if things aren't going the way you're anticipating, I think is very key. And then thinking about how you might respond to any resistance, both ahead of time and along the way after implementation, can be helpful. And there's 3 buckets that you see here in this table, which have varying levels of response, types of response associated with them. And I think that can go a long way to helping you feel more prepared to dealing with challenges that come up. And then we talked about low-hanging fruit, something as simple as having an opportunity for kudos at each of your in-person meetings for your team. So you identify someone who's particularly helpful or has identified a potential problem, and you give them kudos at the beginning of the meeting. So that helps reinforce acknowledge the challenges and the hard work that they're putting into the changes that you've proposed. If you do feel like it's a very heavy lift for your team, you can consider phased implementation. So maybe you just start with one surgeon, which was done by our cardiac surgery service at our institution with their ERAS. We elected to include all bypass patients and all surgeons, but we did tell surgeons, look, the way this works is you have to communicate that the patient is enhanced recovery in order to book them correctly and initiate all the anesthetic and preoperative components. And if that's not done, if you don't feel they're appropriate, they'll get the traditional pathway. So that did provide us with some variation in who was enrolled in the enhanced recovery pathway. I can't say enough when you're thinking about how to measure and evaluate change about using the electronic medical record. Not only do things like order sets help support your process changes, but you can use the electronic medical record changes you've created to help track whether or not the changes you've set out are actually occurring. And if you already have an order set, just change it. Don't make a new one, because people will go back to the old order set. And the less changes that you ask people to make, the easier off things will be. Then you can use those planned process and outcome measures on a dashboard, and you have both a goal and when there's an area of concern and what to do about it, and a person who's responsible for both creating the data and a plan for how frequently you're going to communicate that with your group. And I do think that developing lasting change is not just about reviewing the numbers, it's about recognizing the people behind the change. You have to set expectations that the change is hard and that will be a little bit chaotic, because that's just the expectation for change in a healthcare system. But if you do that and you communicate and celebrate along the way, I do think it can go a long way to helping you be successful. So what did this look like for us? Timeline, it took us about 15 months from the time we set up our committee to the time we went live with our first patient, which was a little over 2 years ago. As I mentioned, patients to be enrolled in the enhanced recovery pathway and really benefit from all the different elements, the surgeon had to communicate with the care team. So some patients had enhanced recovery if they ended up getting more than 70% of the key elements. And if they didn't, they were considered part of the traditional pathway. You can see the demographics here. They were very similar with some small differences in whether they were former or never smokers, not significant from my perspective, although statistically so. The surgeries that they received, vast majority of patients had an infrainguinal target, but similar operative time. But there were some differences in both the urgency and bypass indication. So if patients came in with an urgent or emergent indication, which of course fits with the CLTI or acute limb ischemia categories, they were less likely to be enrolled in enhanced recovery. And it boiled down to more challenges in evenings and weekends with communication to the care team, which varied much more widely than when patients were booked electively, about enrolling those patients in enhanced recovery. And that has improved with time. Not surprisingly, those patients who had more acute limb ischemia and CLTI and urgent indications had higher blood loss in those procedures. And not surprisingly, when you have enhanced recovery patients receiving the majority of the elements, they have a higher compliance rate, both in the preoperative and postoperative phases. But the key point here is that the traditional patients did still get a lot of those postoperative elements because of the implementation of an order set. Where they missed out was on that preoperative and intraoperative phase, so the anesthesia components and the preoperative education and prep. In spite of some of those challenges, we did see some positive impact on our length of stay and some of our outcomes. So enhanced recovery patients had 5 fewer total and postoperative length of stay days, less return to the OR, and although not statistically significant, fewer unplanned readmissions and lower mortality, for an overall improvement in our outcomes for bypass patients and our VQI module. So in summary, enhanced recovery after surgery protocols are a great way to improve both patient outcomes and experience and the experience of your care team. But it does take a village, and so I think setting expectations and frequent and consistent communication can be very helpful in overcoming some of those barriers. There's a QR code there to some of the best practice guidelines that have been discussed in the webinar today. And also the aortic guidelines. Also, I want to put a plug in for the Quality Improvement Committee, which has developed quality improvement toolkits, which may be helpful in implementing projects like enhanced recovery. More exciting things to come with some ERAS specific resources in the works. Thank you so much.
Thank you so much, Dr. Vavra. And our final speaker tonight is Dr. Leanne O'Banion. She is an associate professor of surgery at University of California, San Francisco at Fresno. She has focused her clinical research and much of her clinical practice on limb preservation and ERAS pathway implementation, particularly in vascular amputees. She has published more on this topic than anybody else in the world, and I'm delighted to hear from her. Her presentation titled ERAS Major Limb Amputation, How I Do It, and the Current Guidelines. Thank you, Dr. O'Banion.
Good evening, everyone. My name is Leanne O'Banion, and I'm going to be here talking about ERAS for major limb amputation, how I do it, and current guidelines. These are my disclosures. PAD is estimated to affect up to 12 million Americans, which is an increase of nearly 25% over the past 10 years. And patients with vascular disease account for more than 80% of all of the lower extremity amputations in the US. And what this tells us is that we're facing an epidemic of patients with limb loss, and we need to do things to find out how we can optimize their outcome and how we can get them living a better quality of life and ambulating with functional independence. Now, despite advancements in open and endovascular strategies, major amputation rates remain constant, and only 15 to 30% of patients are reported to achieve ambulation and functional independence post-major amputation, and this is in a modern era. And despite our best efforts, the estimated 5-year mortality still remains over 50% in patients with major amputations. So what makes a successful amputation? Well, clearly we want to remove all of the dysfunctional and devitalized tissue, and that's our primary goal. However, beyond just getting a successful amputation and getting them through a successful surgery, we want to preserve life and limb and ultimately prevent pain, because that's what most of these patients with CLTI are faced with. And in preventing pain, we want to reconstruct a durable and functional residual limb that they can not only live pain-free with, but also have functionality and live independently. Patients, vascular patients specifically who are suffering from major amputation are typically older, frail, multiple cardiovascular comorbidities with higher rates of postoperative morbidity and mortality. And thus they deserve a little bit more special attention than, let's say, the young trauma patient or the person who's losing their limb due to a sarcoma who has minimal comorbidities. And so improving postoperative outcomes really boils down to utilizing ERAS pathways. ERAS has been widely used in other surgical subspecialties with a lot of success. And so specifically in patients with major amputation, the aim of an enhanced recovery after surgery pathway is going to be to have adequate pain control, early mobilization, reduction of edema, prevention of contractures, avoidance of postoperative complications, and facilitating weight bearing, all with the goal of returning to functional living. And what this is going to hopefully lead to is faster recovery, fewer readmissions, and overall increased staff and patient satisfaction. So looking at what the evidence says, well, Dr. McGinnigal did a systematic review in 2018 looking at all enhanced recovery after surgery for all vascular operations. And starkly, what was found was that there were only 19 vascular ERAS studies in the literature, which I think is pretty alarming. And even more alarming is that only one of those papers described vascular patients with major amputation. And so overall, what the findings of this study were that the quality of evidence is poor, the abundance of evidence is limited, and that we really need to do better. So about that time, about 6 or 7 years ago, at our institution at UCSF Fresno, we decided to kind of take things into our own hands and do our own ERAS-based pathway for patients suffering from major amputation. So the big question was, does implementation of a standardized protocol utilizing a multidisciplinary team approach in vascular patients undergoing major amputation improve outcomes? Now, because this wasn't standard of care, this actually had to be done under the auspices of a clinical trial. And so these patients had to be consented, they had to be enrolled, because ERAS really wasn't something that was standard of care amongst vascular patients. So the first thing that we had to do was demonstrate a need. And so we did a retrospective analysis of all of our patients. And what we found was that patients who got early physical therapy and early multidisciplinary care actually mobilized sooner and left the hospital sooner. And so we thought, well, that's a really key piece to the ERAS-based protocol, was early mobilization, and you can't mobilize early if your pain's not controlled. And so how is this multidisciplinary group going to affect the patient outcomes and get them out of the hospital sooner and also get them ambulating faster? So we implemented an order panel. We have Epic at our hospital, and this order panel, the moment someone is determination for major amputation has been made, this order panel is placed. And what it does is it activates the multidisciplinary team. It consults the prosthetist, case management, physical therapy, and occupational therapy, in addition to anesthesia, to all go and talk to the patient about expectations. Physical and occupational therapy do an intake assessment of functionality and start to discuss those rehabilitative exercises. And then the prosthetist also discusses the need not only for what's going to happen in the perioperative period, but whether or not they need psychosocial counseling, because as we know, this is also a huge unmet need in this patient population. Once the amputation has occurred, then the patient gets fitted with a rigid removable limb protector. The Foley, if it was placed, is removed on post-op day 1, and patients begin working with physical therapy and occupational therapy, and then with the anticipation that they're discharged to an acute rehab facility if appropriate on post-op day 2. Once they're discharged, they're established with an outpatient amputation coordinator who helps ensure that all their follow-up is outlined, and they're a connective resource for the patient if they have any questions or concerns, or if their family has any questions or concerns. Staples or sutures are removed at 3 weeks post-op, and then they get that initial mold of their limb by the prosthetist at 5 weeks, with their initial prosthetic fitting at 8 weeks. And then we typically try to follow these patients at 3 months and then yearly thereafter, especially if they have a foot on the other leg, because it's so important to have preventative medicine at this time, especially in patients who have a history of CLTI or poorly controlled diabetes. What you can see here is these were the early results of our pilot study, and there was a significant reduction in days to receive a prosthesis in those patients who underwent ERAS pathways. Additionally, those patients who were discharged to acute rehab, which all of them in the pilot study were, had a significantly shorter time to receiving their prosthetic. And so discharge destination, this was the first time where we really saw acute rehab discharge destination matter. And so once we went through that early pilot phase, we then were able to convince the hospital that we could now implement this as standard of care. And so we actually expanded it to all 3 hospitals in our system. And what you could see here is that when we had 63 patients who underwent the ERAS amputation pathway, you can see the difference in use of multimodal analgesia, use of a limb protector, counseling provided to the patients, and then they also got off bed rest sooner and had a shorter length of stay, and also they were more likely to go to acute rehab. And so the overall conclusions from this study were that LEAP decreased the odds of a post-op length of stay greater than 4 days by 77%. Patients had a statistically lower rate of phantom limb pain, and they were more likely to receive their prosthesis. And an ERAS-based pathway was associated with an 84% reduction in time to receipt and ambulation with a prosthesis. And so another thing I kind of wanted to touch on is, what is optimal long-term ambulation? Well, a lot of us think ambulation means that you put your prosthetic on and you walk like you or I would. However, in this patient population, it was our thought that even if you were able to just put your prosthetic on and you transfer to the restroom or transfer to your wheelchair so you can get to the kitchen, that you have some component of independence and mobility that's going to significantly impact your long-term outcome. And so this is how Medicare describes it in terms of K level. And so what we described as mobility was anything over a K of 0, which means you're putting on your prosthetic and you're able to transfer or ambulate at a level surface at a fixed cadence. So what you can see here is we then looked at the outcomes, and patients who got an ERAS pathway were more likely to receive multimodal care from both an anesthetic and a social work, physical therapy, counseling perspective. And they were almost 4 times as likely to walk with a K level greater than 0 than historical controls. And this was a huge, goal for us, considering that if you can see here that over 56% of our patients are Hispanic. And what I don't have shown here is that we have an ADI in this cohort, which is a measure of socioeconomic disadvantage of 9 out of 10. So this is a really challenging patient population to have success in. And so once again, when you took all of that data and put it into a multivariate logistic regression, you can see that ERAS-based protocol is the only significant predictor of a K level greater than 0 with an odds ratio of 5.8. So pretty impressive. And then when looking at mortality, you can see that any patient that has a K level greater than 0, so any component of using that prosthetic, has a significant reduction in mortality, which I think is really important, considering that for decades we haven't been able to move the needle of that 50% mortality in patients with major amputation. And you can see this is even further demonstrated in the survival curve, and you can see a 40% reduction in mortality in patients who are using their prosthetic. And so how do we translate this into something that any hospital can use and make it into guidelines? Well, we recently published a framework for perioperative care for patients with lower extremity amputation, and this was a joint effort between the ERAS Society and the Society for Vascular Surgery. I have to give Dr. McGinnigal credit here for putting together an amazing group of multidisciplinary physicians who were really dedicated to seeing this group of patients exceed their in their care and optimize their outcomes. And so a couple of things that I just want to point out that were key findings of this project were that we really stressed the importance of multimodal analgesia, including regional nerve blocks, preservation of the knee at all costs to enhance functionality with a prosthetic, avoidance of a urinary catheter when possible, good glycemic control, particularly in patients who have diabetes. Once again, that early mobilization with the intent to go to acute rehab. And finally, I touched on it, but mental health assessment, really getting these patients early on discussing whether or not they need any psychosocial support. So in conclusion, ERAS really does afford long-term functional ambulation in a socioeconomically disadvantaged and frail patient population. We can decrease post-op length of stay, we can decrease phantom limb pain, and we can expedite time to receipt and ambulation with a prosthesis, which does confer a significant survival advantage in this community. And this really gives us an opportunity to bridge that healthcare gap utilizing a disease-specific standardized protocol. An ERAS-based multidisciplinary care pathway for vascular amputees will lead to sustained results beyond the perioperative period. So thank you for the opportunity to talk. I'm excited about the discussion that we're going to have tonight. And thanks again to Dr. McGinnigal for all of her hard work in this space.
Thank you so much, Dr. Banyan. You're too kind. And thank you to all of our other speakers tonight. Due to the local time in Europe, not all of our presenters are going to be here live with us tonight for the panel discussion, but many of us are here. So if you all could please turn on your cameras now. And I'm also happy to introduce Dr. Joy Garg, who is the Chief of Vascular Surgery at one of the Kaiser hospitals in California. He participated in writing all 3 of our different ERAS documents and is here to answer questions as well. Also, quick reminder that we will have a post survey that will pop up on your screen in just a moment. Please answer the questions again. Now that you perhaps have had some new knowledge after the presentations this evening, hopefully you can answer a little bit better than the first time around. And while you're working on that, we can review the Q&A questions. If you haven't had time to add a question, please feel free to do so at any time throughout the discussion. General question number 1, I can see, related to some of the data presented for the bypass patients at Northwestern and also amputation patients at Fresno. Do you think patient selection has any impact on the outcome data you shared? Or is there a difference between the ERAS and non-ERAS patients? Dr. O'Banion, you want to take that one?
Yeah, sure. I mean, I think prior to the implementation of ERAS, there was certainly a selection bias in who we were saying we thought was going to ambulate or what we thought weren't going to ambulate. But now that we've moved to kind of a standardized ERAS-based protocol, everyone gets the protocol. Everyone that has an opportunity to use a prosthetic in any function. So unless you're completely bedbound at a nursing home or have a cognitive dysfunction that would prevent you from even transferring, you go through ERAS pathway. And so by eliminating that selection bias, I think we reduce care variation, and that in and of itself has been shown in the literature to improve patient outcomes.
And I think I'll add, because, one of the things that might have prompted the question was that we looked at our non-traditional pathway versus ERAS pathway and just compared those patients that received the majority of the pathway versus those that were slightly deficient. And that was mostly because we wanted to identify what the barriers to implementing ERAS might be. Because I think whether you have a best practice that you think you're implementing on all patients or not, there's always going to be situations where it's more challenging to implement those best practices than in others. So not surprisingly, in emergent or in urgent cases, it just becomes more challenging to get some of those elements through the door. And so even in those patients that are listed as traditional pathway in our analysis, they still got a big portion of the pathway, but it just tended to loaded into that post-operative phase because it was just much easier to implement those elements when they weren't going straight from the emergency department to the OR. They couldn't get their drink, they couldn't get their preoperative education, and all those other elements that we considered important for ERAS. So our overall cohort outcomes did improve. And I think if you look at it that way, then there's still a huge benefit, not just to the patients, but to the care team. And I think that setting the expectations that all patients go through those elements over time, your barriers tend to be less significant. And that was what we experienced.
I think something that's also important to remember is that with ERAS, it doesn't have to be all or none. You get a patient from the ER, take some time to get up, you can't get the card brink like you mentioned, or whatnot, or get a frailty assessment, but you can still do the multimodal pain management afterwards. You can do early ambulation. Just having some of those elements will still make a huge difference in the recovery of the patient.
Yeah, absolutely.
Dr. Garg, why don't you tag on to that? One of our other questions is what guidelines are you following around the early mobilization in those most frail patients?
So I'm a bit more aggressive than some of my partners because I was involved with these guidelines. Some of the frail patients, so we have in our recovery unit in PACU, we have physical therapists there all the time because we're also recovering post knee and hip patients, and they're walking those very same patients. So I have my own little triaging that I do. In a patient who I did not necessarily cross a joint, if I just did, let's say, an above the knee fem pop, I have gotten the physical therapist, if the wounds look stable after about 4 to 6 hours, start getting them and mobilizing the patient, at least stand up out of bed, take a few steps. And it's actually worked okay. You look at some of the historical data and you wonder about hematoma development or did you disrupt your anastomosis? Nothing like that occurs. They do very, very well. And there's some patients who just aren't ready, but my practice has been very aggressive physical therapy by at least post-operative day one. Every single one of my patients by post-op day one has gotten up with physical therapy, or on the weekends, if it's the weekends, with the nursing staff. They have a good set of protocols here with 2 nurses to walk them.
Yeah, and I would add to that, there's always incremental movement that can happen. And so, even on the evening of surgery, there's no reason why a patient can't sit up on the edge of their bed to eat dinner, or transfer to a chair to eat dinner. And that counts, right? That really helps kind of keep people oriented and, get them kind of coordinated and thinking about the confidence that they need to do some more movement the next day when physical therapy comes. All of that counts for early mobilization, even in the highest risk patients who need help to transfer.
Kate, I'm going to just add a little bit further than that in terms of prehabilitation of sorts. And so I think, even in the patients who have chronic limb-threatening ischemia, who have a gangrenous foot, you're going to do an amputation, they can start doing upper extremity exercises. Expectations can be set by physical therapy, and generalized functional assessments can be done, because one of the big barriers that I think we have in our healthcare system is the hoops that we have to jump through to get patients to acute rehab and to get discharged from the hospital from a social work perspective. And so just those additional notes by physical therapy early on can help, get the ball rolling, so that if they're going to be discharged on post-op day 2, that can be an achievable goal if all the necessary steps have been taken by physical therapy.
That is a really good point. So while we're on the prehab and kind of getting ready before surgery concepts, there's another question about nutritional support strategies. They're specifically asking about, what nutritional screening does one do, or are there any consultations that you get preoperatively or things that you work on postoperatively once the patient's in the hospital? Dr. Vavra, you want to tackle that one first?
Yeah, sure. So we implemented for our bypass patients was like a simple nutrition screen, which we haven't really used to implement any preoperative changes yet, but just to gather data so that we could do a retrospective analysis about those patients who are most at risk for nutritional deficiency and how their outcomes varied and how they may potentially be candidates for more rehabilitation prior to surgery when that's feasible. We also do the carbohydrate loading drink, and there's a variety of different options for that. What we chose was the Ensure pre-surgery drink, which is a clear liquid drink. Its contents are a little bit different than the G2, the Gatorade option, which in our experience, to get the same sort of equivalent amount of carbohydrate, you end up doing a much larger volume of the Gatorade. So the Ensure pre-surgery was preferable to us, and was available, or an option that our hospital was willing to support. So that's what we particularly use. And then we do protein supplementation post-operatively for all of our patients with their meals. I
Yeah,
don't know if
I mean,
anyone
I
else
would
does
say that
anything differently.
a tip that I got from a nutritionist I work with is just a very simple screen that I do in the clinic now with a lot of my patients, because certainly a lot of these patients are at risk for malnutrition, and a lot of them also suffer with food insecurity. And so I just kind of ask, like, do you feel hungry and eat 3 meals a day? Or have you lost weight recently? If you were trying to gain weight, like, could you get enough food to do that? And those were my 3 questions that I asked to kind of get a general ballpark. And if someone is really truly struggling, food insecurity is something that is, a focus of one of the quality initiatives of our hospital. And so there's immediate resources that we can plug in. So when the patient is admitted, that's, another one of the kind of things that you can do to preempt problems that may come up, in addition to some of the therapy problems that Dr. Banyan had just mentioned. All right. So negative pressure wound dressings for groin incisions. So this was something that when we were writing the document, we went round and round because there's a variety of relatively low to medium quality literature with lots of different conclusions here. And so maybe Dr. Garg, Dr. Vavra, well, you two, Dr. Banyan, anyone who wants to take this. Do you use wound vacs on groin incisions or other negative pressure wound dressings? And would you recommend them? Why or why not?
We're about 50-50 in our practice with the partners here. The preferred choice for some of the newer partners has been Prevena, and they do that. The only issue with Prevena is, we're working on discharging these patients out of the hospital after a few days. The Prevena can stay on for up to 7 days, and there's always a question that comes up. Do they need to come back to the hospital to get that removed? And you try to tell patients, no, you can peel it at home and it's totally fine. So it's about 50-50. And in terms of anecdotally, again, the data, as you mentioned when we were looking at it, wasn't superlative one way or the other. Anecdotally, those incisions do look pretty good. We haven't seen them break down.
Yeah, I'll echo that. We didn't find enough evidence to put it as part of our official ERAS pathway. We just stuck with the transverse incision and we leave it up to the surgeon. Usually, if folks do use it, it's in obese patients with a large panos. They're worried about maceration of the incision, and it does seem to work well for that, but that's just anecdotal evidence and bias.
Okay.
Yeah, I would echo that. I think that patients who are high risk, we use Pico pretty frequently. And, we have a large underserved patient population. So patients who are unhoused, patients who struggle with hygiene, I think it's really nice because it is a sterile dressing that's placed on for 7 days. And so we're mindful about putting it on in those high risk situations, in addition to the obesity problems that Dr. Vavra discussed.
All right, we have another question. For those of you in academic medical centers, how do you engage residents in implementing and following ERAS post-operatively? And I'll start with this, and I'll say that oftentimes ERAS is kind of standard of care for my residents. And I have the benefit of working in a large institution that has 20 different ERAS pathways across multiple different surgical departments. And when we have the general surgery residents rotate onto the vascular service, they're very used to doing ERAS and the other general surgery disciplines that have had these protocols established for longer in our hospital. And so a lot of the things that we think are new, like removing Foley catheters and NG tubes early, are just standard for them. And so actually been really beneficial, and they've been very helpful in getting the rest of us faculty and APPs on the vascular service to see the value of ERAS postoperatively. But what about the rest of you? What's your experience been?
I mean, I think residents love checkboxes and they love things that make things easier because they live a really busy, intense, stressful life. So when you tell them, like, here's the pathway and here's an order set, and all you have to do is order the order set and follow these instructions, they're like, yes, that's one less thing I have to think about. So I find they really like the structure of ERAS, and kind of the protocolized aspect of it. So it's actually been really great. All of our residents have really embraced it and they enjoy it.
Yeah, I mean, I was just gonna say all of those things you already said. The only other thing I'll add is we had one or two residents. We have both an integrated vascular program and a fellowship. So we had one representative from each serve as champions amongst the residents. And I thought that was helpful. And then along the lines of the order sets, I see the order set question. Leanne already talked about how the residents they love order sets because they love having expectations sort of laid out for them. And I think that's true for all of the care team. And one of the benefits of ERAS is that it really cuts down on the need to communicate. And if it's standardized across all faculty, it helps all the care team members know what to expect in addition to helping the patients as well. I don't think you need order sets to do ERAS, but I think it's just about trying to make what people do, make it easier to do the right thing. And if your postoperative care is heavily reliant on order sets, it just makes sense to use an order set to help drive change. Because you want to integrate all the change into things that people are already doing. If you're going to ask folks to implement change and change their daily practice, it's going to be that much harder than to say, you're just going to fill out an order set that looks a little different than the one that we filled out a week ago. So I think that's how I would approach that issue. If you're having some temporary issues with having changes in your order set, it may make implementation of some of those postoperative or preoperative elements, whichever the phase of care that order set is applicable to, slightly more challenging, but it's definitely not impossible.
Well, and to answer the question about if your hospital is not willing to have a formal, I mean, I'm going to talk about Epic because that's kind of what I know. We created a specific Epic amputation order set, and that had to go through all of the, rigmarole of the Epic powers that be. But you could also just take one of your standard vascular post-op order sets and you can personalize it to a specific operation and save it as a favorite. And so that could, and then your partners and your residents can steal it and you can share it. And so it doesn't have to be something formalized until your EHR makes that transition. You can just implement it yourself within your division, within your group on Epic or whatever EHR you're in. So there's workarounds.
Yeah, we get residents too from UCSF East Bay, and it's as Kate was saying, it's so nice because they already know the order sets. They just click it and they go, and it's very automatic for us. The other thing that I will stress is that we were involved with our order sets, and I think it makes it infinitely easier to have it because then you have consistency. And if you make changes to your pathway, you just make it on the order set, and then everyone gets that change automatically implemented. Whereas if you have to customize it every time, it then makes it harder to have a defined variable that you can follow what you're doing. So I would definitely encourage you to work with your EMR staff and stress the importance of this.
Yeah, no, I agree. I mean, one of the PAs who works with me has really become the vascular ERAS champion and has taken the order set adjustments under, her job responsibilities. And in my particular hospital, anytime you want to change an order set, you have to get the approval of all 15 UNC system hospitals. And so it is extremely onerous sometimes. And sometimes you feel like it's not worth it and you just want to kind of stick a sticky note up in front of like the workroom computers to remind people what they're supposed to be doing. But if, like my superpower PA, you have the strength to do it yourself or you work with someone who can take it on, I do think it is ultimately worth it. All right, and then remaining, we've got two medical management questions. One I think is exceptionally important, and it's about mental health assessment. And so, Dr. O'Banian, why don't you start? Can we explain the mental health assessment you give to patients and the next steps if they need resources? In particular with issues of, lack of availability of mental health professionals across the country.
Yeah, I mean, I think it's a really that we could talk about this for hours. I think in the outpatient setting, we've implemented a standardized PHQ-2 and then PHQ-9 depression screening in all of our patients, and that's pretty much something that every single patient, whether it's an amputation patient or not, every single visit, every single patient that comes through our office gets a PHQ-2. And then if, and Epic actually has that built in. And so it just gets, if either of the two are positive, it bumps you to the PHQ-9 and they go through it. And I was actually, when we started doing this, I was shocked at how many patients were truly positive for significant depression that didn't already have depression as part of the problem list. And then I think to go a step further, that just kind of reiterates the importance of this multidisciplinary collaboration, because that's where you get social work involved, you get your primary care involved, your hospitalists in medicine involved to plug those patients in, to start them on the SSRIs or whatever medications, critical to them if they're in the inpatient, or get them plugged in with primary care as an outpatient as a start, because mental health professionals are so scarce, but then it kind of falls on the PCP, and we really rely heavily on them to kind of get them integrated into the system. But I think you can start as a vascular surgeon or a vascular provider by just screening your patients, and I think you'll be shocked at how much you're going to find.
Yeah, I'd say we studied depression rates in our patients who had CLTI through our limb preservation clinic last year, and even the people who carried a diagnosis of depression and were already medically treated, many of them still had uncontrolled depression. And obviously when you have pain and a foot wound and you're facing limb amputation, or even just bypass surgery, that's a tremendous adjustment, and it's a very stressful time. And so even folks who you think are already being treated, I think just asking about it and normalizing it and acknowledging that it's okay to be completely overwhelmed is really powerful. And I think that, let your patients know that they can talk to you about it, as opposed to just trying to kind of grin and bear it and potentially get worse from a mental health standpoint.
We do a similar stuff. We have screening questions for every patient when they come in. And the other thing that we're working on is we also have a senior surgical care program, and you can refer as a surgeon when you see a patient that you're concerned about to that program. And before you go to surgery, they'll have a social worker, multiple therapists give them a phone call and make assessments on the patients, and then we discuss those patients and we identify resources that they may require. It is a challenge because there's a shortage of providers. So at least we're trying to employ psychologists along with psychiatrists to try to fill the gap, but there is still a huge gap in mental care.
Hemoglobin, pre-op hemoglobins, how low is too low? Obviously patients who are facing limb amputation or require lower extremity bypass for PAD are going to have concomitant atherosclerosis with coronary and cerebrovascular risk. The poster prefers a hemoglobin of 9 as opposed to a hemoglobin of 7. Anemia screening is one of the things that we recommend. And I think also delaying surgery if you can, to work on iron supplementation and other ways to address anemia. But what's your hemoglobin number that you guys live with in patients with PAD?
I'll go down to 8, but there's new literature that they always talk about, the HBS doctors that we have here, so you can go lower, but I get nervous.
Yeah, I think it somewhat depends on the urgency of the procedure. I mean, obviously, if you don't have enough time to wait to correct their anemia, then that complicates things a little bit. We do have the advantage of not just having a screening process, but our preoperative clinic has a very well ingrained process for iron supplementation, even IV iron supplementation, and they'll do that just in the pre-op area for some of our emergent cases. It's not to say that you'd expect their hemoglobin to come back magically normal, but at least they get some of that iron supplementation, which may help reduce some of the negative impacts of the anemia in the postoperative phase. But it does I would love a hemoglobin of 9 patients. That would be great. I agree.
Yeah, I mean, I know 7 is safe, but anyone who's been down to a hemoglobin of 7 knows that that feels terrible. And so I think, you know, while we know it's safe, oftentimes I'll pull the trigger and like to get them around 8 or 9, you know, especially if I'm doing an operation. There's a lot of data on both ends of the spectrum, and I don't know that we'd have a hard and fast answer.
Yeah. All right, well, that brings us to time. Thank you very much as we close out our program. Thanks again, once again, to our presenters, Dr. DeBoer and Settembrini from Europe, and then those of you who could join us in the panel, Dr. Vavra, Dr. O'Banion, and Dr. Garg. Thank you, of course, to all of the attendees for joining and participating with us. We are all available to answer any other follow-up questions, and hope that you reach out as you're working on your own ERAS programs. Additionally, this webinar has been recorded and will be available on the SVS website. So thank you all very, very much for your time and attention, and have a pleasant rest of your evening. Take care.